to the third webinar of the AACDP series titled Building a Sustainable Local Oral Health Program. My name is Joanna Albo, and I'm a Health Program Manager with the Office of Oral Health at the California Department of Public Health. And today I have the pleasure to be here with you all again as co-moderator. We value this opportunity to present today's topic via webinar, joined by our experienced panel of presenters, and thank each of you for your participation. Today, I'm happily working alongside our program organizer, Katie Conklin, and our moderator, Dr. Larry Hill. Dr. Hill, I'd like to turn it over for you for introduction.
Great. Thanks very much. I want to welcome everybody here this morning or this afternoon or whatever your time zone is. And a couple of notes before we get started. The American Association for Community Dental Programs is very pleased to be able to bring you this program this year in our co-sponsors for the program, the California Department of Public Health, the Oral Health Section, and California Dental Association. Other sponsors, and this is a first this year for us doing this way, and our other sponsors include the DentaQuest Foundation, the American Dental Association, and ADEC. So I want to recognize them and thank them all for their support for helping us to put this meeting on. Also, I just want to mention right up front for those of you who may know Myron Alukian, who is a long time dental public health person, former dental director for the city of Boston. Myron was on a ventilator with COVID for a little over 3 weeks. And he is off the ventilator now. And actually, I heard yesterday that he spoke to one of the California colleagues, Jared Fine, and so I understand Myron is on his way back, and we're really pleased to hear that. So now, to get right into the program, I want to introduce we're going to go through each speaker, and we'll ask you to hold your questions till the end. You can go ahead and start to enter your questions on the is it the chat area, I think, or there's an area for you to answer your questions to ask your questions on the screen. So we'll ask you to go ahead and do that. We'll hold the questions until the end of the presentation, except for our first speaker, Gayle Mathe, who unfortunately is going to have to leave soon after her presentation. So we'll address some of the questions that we have time for Gayle immediately after her presentation. So to introduce Gayle, she's the Director of Community Health Policy for the California Dental Association. Before coming to the California Dental Association, she practiced dental hygiene for nearly 30 years. She's made significant contributions to several key policies in California, including advancing and maintaining water fluoridation, dental Medicaid reform, advocating for the Office of Oral Health that would be led by a state dental director, which has obviously happened now, and a number of other areas. So I first met Gayle. I remember meeting Gayle many years ago on an elevator and hearing that she was the dental hygienist of the stars at that time. So I can't mention the stars because of HIPAA, but she treated some very famous people. So it's my pleasure to introduce Gayle.
Thank you, Dr. Hill. I totally forgot about that. Yes, in my dental hygiene days, I practiced in Beverly Hills and in Hollywood. So thank you for that reminder. It's really a pleasure to be here today. Thank you all so much. And thank you to everyone who creatively managed to move this from the format it was to the format it is in now. I know that took a lot of work, and thank you to everyone that were involved in that. I also really want to acknowledge that the slides you're about to see were put together when we first envisioned this back in like February. And they don't reflect the COVID pandemic, the health and economic toll of the pandemic, the way things will change as a result of that, which none of us actually know what that looks like, but we can certainly feel the changes. So what you're seeing here is really a look at history and recent history and really the potential for the future. But I didn't change the slides at all as a result of the current pandemic and the conditions of that. But I would also say that the foundation of this presentation is about commitment and partnerships, and those remain the same. So next slide, let's go ahead and look at this first slide. Move it forward if you can, keep going. So this slide, when I was first asked to present, I was reminded that a few years ago, Dr. Jared Fine, Dr. Jay Kumar, and I presented to the National Oral Health Conference on the building of the oral health infrastructure in California, kind of the beginning of really seeing that happen. And I looked back at those presentations, and the slide you see here is actually Dr. Fine's. Thank you, Dr. Fine. It just so captured it so well, I thought I would begin my presentation with his view back then. And the first bullet, public health and organized dentistry. This was actually really the way this happened, and the partnership and moving forward together. CDA's bold action refers to the work that CDA did to establish kind of our commitment and our direction in this. Leading the way, staying the course. No doubt that's what it's been over the last few years. Show me the money, I'll get into that. And public health takes off, I'll get into that a little bit more as well. Next slide, please. So this begins mine. This is really about commitment, partnerships, and resources. That's how we have moved forward. 8-10 years ago, CDA did some significant work, volunteer-led and driven, to look at how do we reduce barriers to oral health care and dental services in California. And that from that came a 3-phase multi-year plan, blueprint sort of how we can move forward and where we can focus. And it prioritized the need for a strong public health infrastructure. And this was really where a lot of commitment and understanding came from, because as we did that work together, and as volunteers and the members and the leadership in CDA did that work, it became very clear that all of us were necessary, private sector, public sector, to create a really full net for the care that people need and the improving oral health in California. That resulted in bringing Dr. Jay Kumar, that prioritizing the need for oral health infrastructure and a oral health office, effective programs in California. Dr. Kumar arrived, and then we turned our attention to pursuing sustainability. Next slide, please. So the sustainability piece, just really briefly, this came through Proposition 56. This was an initiative that passed in 2016, overwhelmingly in California. And it didn't come out of nowhere. So it was really the right timing for this. California's tobacco taxes was one of the lowest in the nation at that point in time, 87 cents a pack. Our legislature had been working for a couple years on advancing tobacco policy, and they'd made some advances, but it was incremental. But that work in the legislature brought the awareness into the public about the toll that tobacco use is taking on the healthcare system and the lives of Californians. And another element was that e-cigarettes, electronic cigarettes, and the kind of widespread, the steep climb, we'll say, of youth was really starting to worry the public. So there was an interest, more of an interest in the public on the regulation and the control over e-cigs. A very effective coalition of virtually everyone you could think of came together to support the proposition. This is that it overwhelmingly was successful. And it raised a pack of cigarettes from 87 cents to $2.87. So raised it by $2, and it did some regulation and taxation on e-cigarettes as well. That's that left-hand square. The other 3 squares are what resulted from that funding. We were able to advocate for 30 million of that annual funding to go to the State Office of Oral Health to support the implementation of the oral health plan and the programs envisioned there. Medicaid rates across, in California, it's Medi-Cal, rates across the services that are provided were where most of the rest of the funding went. Really, it's dedicated to that. And dentistry saw a significant rise in the resource support for Medicaid services. And then we also have a very innovative program for not only loan repayment, but practice relocation into areas of greatest need in California. So I'll talk a little bit more about those coming up. Next slide, please. So let's look at the $30 million to the State Office of Oral Health. California has 58 counties, and much of what happens at the local level. Prior to this, there were very few counties that had any resources or focus on oral health. We had a few superstars, Dr. Fine, and was followed by Dr. Amanzadeh in Alameda, and they had been working in this arena very effectively for a very long time, as had a few other counties, but most really didn't have anything happening in the oral health specific realm. So out of the 30 million, 18 million is distributed in grants from the State Office of Oral Health to those local jurisdictions to really begin to create systems there. So to hire staff, to do community needs assessments, create strategic plans. And some of the priorities of those local programs are to support and expand the implementation of kindergarten oral health assessments in California. That policy was adopted in California in 2006, but it's had inconsistent implementation. The advantage of consistent implementation across California is really as a marker for what's happening in the 0 to 5 realm. How successful are we in programs, early programs? What are we seeing about the regarding the oral health of children as they come into the public school system? Also, school-based prevention. We lost our school-based prevention program, and it was a fairly minimal one, serving a little over 300,000 children back in 2009 recession. But so reinvigorating, how do we do school-based prevention in this day and age in California, and creating a system that really also looks at community linkages. How do we serve children in the community, in the schools where they're at, but how do we make sure they are linked to the resources for care in the community? And then water fluoridation. The last 20 years have seen a lot of change water fluoridation in California. In the 90s, only about 17% of Californians had access to optimally fluoridated water. A lot of work has gone on in the in-between. Legislation, significant grant from California Endowment, significant advocacy. Californians now have about 60 or low 60% of Californians have access to fluoridated water now. That's huge. The local health jurisdictions are really a place to be protecting that, maintaining it, educating their communities about the benefits of fluoridation, and just recognizing that it is a priority in the prevention work that they're doing. Next slide, please. The other work that's gone on in California that's really been partnerships across the realms, private and public, has been the expansion of the virtual dental home. I think most of you are familiar with the virtual dental home. It is really a hub-spoke process or methodology that allows individuals in the community to receive services and assessments. Dental hygienists are often in sites within the community, either schools or Head Starts or elder homes, SNFs. Those individuals in the community, those dental professionals in the community can do quite a bit to assess needs and maintain and provide preventive services to individuals, but also those individuals are linked back to a hub where a dentist is able to see records that have been collected, help with diagnosis and create treatment plans, determining needs and how management is best handled, and serving as sites for higher level care. So that the virtual dental home is a great name because the same thing you would get if you walked through a brick and mortar place for dental care is the goal. That optimal comprehensive ability to receive care is the goal of the virtual dental home. And then again, school-based prevention programs, we're seeing a reinvigoration of how do we do that and how do we do that with good linkages for care. Next slide, please. This slide is particular to the local health jurisdictions and programs in California. My presentation is a lot about we get where we get through partnerships. None of us do this alone. And our messages internally at CDA are very, very frequently, know what's going on outside of your dental office. We know you are focused on the dental care in your, with the people that come through your door, but engage, because the community is doing a lot too. So if you're a local program in California and you don't have a good relationship right now with your local dental society, you're not in contact with them, you don't know their dental director and speak with their dental or their executive director at the local level, I would point you to CDA's homepage. You can find that contact by clicking on the menu, so that's the left orange arrow, and going under About, and then all the way down that list to local dental societies. You can search there for your local dental society with the contact information. I strongly encourage you to reach out if you don't have a relationship now. If there's any bumps in that at all, please contact me. We need to come at it from both sides. And those are long-term relationships where that work gets done. It's just being in contact, knowing what's going on, partnering where we can. So that's what this slide is about, is to help you and let me help you if there's any disconnects there. Next slide, please. I'm going to pivot a moment to some other work we're doing in partnership with the State Office of Oral Health. CDA, we're very lucky to have a journal where we really have a chance to look mindfully at how do we use the journal to communicate with the profession, provide education, provide best practices, raise questions and research and inquiry. And our work with the State Office of Oral Health has included the things you see on the screen here. So early on, what's the oral health status in California, the needs, publishing the state oral health plan. We have in the subsequent years, the last few years, provided research and information on tobacco counseling, on opioids, on antibiotic stewardship, on oral health literacy. And coming up, as the State Office of Oral Health starts to publish data briefs from the work that they are doing, the journal will also be highlighting those things by including them to disseminate to the professionals that read the journal. So this is an exciting place where we partner, and it's been really very satisfying to be able to do this in conjunction with Dr. Kumar and the State Office of Oral Health. Next slide, please. So I'm going to flip back to tell you a little bit more about the work that's gone on in those other couple buckets. So Prop 56 brings in a significant amount of funding into California. And as I mentioned before, the bulk of that does go to support the Medicaid program across all services. That runs in the, I don't have exact figures, it's somewhere in the $750 million, I think, to 700 million to $1 billion, kind of somewhere in there. And when you add the federal match, it's a significant amount. About 700 million, I'm sorry, I'm looking at I think go to the medical providers. Dental gets, I think, close to 200 million. And these are very round numbers. I would not quote me. My old brain cannot hold these things very well. But I'm trying to give you the scope of that. What has happened, what is important to recognize, is that payments to a broad range of important essential dental services to Medicaid members were increased by 40%. And we have well over 1,000 new enrollees, dental providers who have enrolled in the Medicaid program as they see the opportunity to provide this care in a sustainable way. CDA also partnered with the Department of Healthcare Services that runs our Medicaid program to develop TYKE, a training for how do you do need-to-need risk assessment, how do you do a risk-based approach to the care you provide for children under the age of 6. This was actually a pilot in the California Medicaid program. under the Dental Transformation Initiative, which I'm not going to go into in depth here. But that initiative has also made a difference in our Medicaid program. And CDA developed this training along with the Office of Oral Health and other experts, Dr. Jared Fine being one of those, as a matter of fact. And that is offered for free. That training is offered for free on CDA's website to anyone who wants to take it. And it does provide free CE units as well. CDA supported that to make sure really that this information is easily available to dental providers. The next bullet on here is very in the weeds. Just for those who would wonder what this means, our Medicaid program was using CDT codes are the codes that are submitted for claims across dentistry, commercial and public programs. And our Medicaid program had used very outdated, 2012, 2013, something like that. And we've worked very hard to get that up to a current CDT code so that dental providers who are in the program can actually accurately file those claims. They're not working kind of in two different systems. So in the weeds, but that's what that is. And the last bullet here really reflects where we were when I wrote this. Our advocacy really began to be focused this year on what more can we do to increase the access to care for special needs? Where are those barriers and those bumps? And while we have had to pause on that work, that is certainly work that continues to be important. And we all look forward to resuming all of the important work, including this, when we can. Next slide, please. So I'm moving into my last couple of slides here. I want to tell you about the Cal Health Cares program. This was the loan repayment, or the 5-year program that I talked about earlier on in this. This is a significant commitment. And again, it's across healthcare, not just dentists. It's many other medical providers, healthcare providers. This is a significant commitment by our Department of Healthcare Services to dedicate some of the Prop 56 funding to support medical and dental practices in areas where there's need. And in many cases, it's difficult to sustain a full practice there, so you don't see people naturally moving to those areas to practice when they have those kinds of concerns. So the Department of Healthcare Services has made a significant 5-year commitment, dedicating $340 million out of Prop 56 to not only pay back student loan repayments, which are more familiar in there are many several student loan repayment programs that are available, but also to provide practice relocation grants. If there is a dentist that wants to open a practice in an area where they're concerned about sustainability and they need some help creating that, this is what this loan or this grant program is for. 50 million of this money has been dedicated for relocating dentists. And in 2019, which was the first year where those awards were made, 38 dentists received awards and for a total of 10.1 million. These awards are $300,000 each, top, $300,000 each. Let's go to the next slide so you can understand what the requirement, the commitment is. So it's a significant service obligation. Those who accept these grants or these awards will need to maintain 30% of their practice serving Medi-Cal members. They have a commitment of 5 years for the loan repayment and a commitment of 10 years if they received a practice relocation award. So significant amounts of money, significant commitments, and of course everyone will be watching closely to see significant results. And the last bullet here on this page makes me smile because back when we were putting this together, I had been talking to small local jurisdictions in California that we're trying to figure out, how do we get in front of dentists? Like, how do they even know that we need somebody, if I'm Sierra or if I'm Trinity? So we were putting together a booth at CDA's annual conference in Anaheim, which has a huge attendance, thousands, 15, 20,000 dental professionals. we're putting together a booth where local jurisdictions would be able to come and talk up their counties. This is why it's wonderful to live here in Trinity, and this is what you can do, or Humboldt, or whatever it might be. So we were all excited about matching up, finding the dentist that might be interested with the community, and we will have to turn our attention back to that when, again, things get back to normal, because the annual conference was canceled, as was this and all others. So I think those are my main messages. I would, yes, my thank you. I'm happy to take a couple questions if there's time to do that. And please feel free to follow up with me directly if there are additional questions, or again, I can support in some way. Thank you so much.
Joanna? Hello?
Hi, thank you so much, Gail. That was great. I think Joanna may have lost her connection for just a moment, but I do believe we have some questions for you from the chat box. And we had a question on organized dentistry. Gail, like, how do you see, you were talking about the local level of CDA and how important partnerships and relationships are of really bringing together organized dentistry with public health. And in this time of what everyone's going through, I mean, there's been so much curiosity now on how these two kind of come together. What are your thoughts on that? Just kind of summing up your presentation a bit.
I appreciate the question. Actually, I didn't focus on this quite as much as I meant to. You know, while I touched on the partnership, I think meant to include my experience of this is that it has really taken time and commitment and relationship. I know I said that in the beginning, but you know, in California, there are dentists in the public health realm who are active members in their local dental societies. They don't just come to the dental society and say, hey, can I present? We're doing something in California, you know, in our local area that we'd like to talk to you about. And while that happens and while that's important, they're an integral part of the fabric of the volunteers in the dental society, making relationships, doing the work kind of, and then rising up through leadership. A good example of this is just recently, so Ariane Turley, many of you may know Dr. Turley, she's our vice president. She will be president in a couple of years of CDA. So there is a long-term, it's not done kind of overnight, long-term understanding of each of the worlds. You know, this is what I do and this is why I'm focused, and this is what you do and this is where you're focused. But at some point you start to see the crossover, and that's really what has happened in California. How do we help each other? Mm-hmm. So at the local level, I think particularly because local health programs are just beginning in lots of places, I would view this as a long-term investment. You probably can get some short-term buy-in for, we've got this thing, can you send some volunteers, or we're hoping to do a screening, and you know, those things are tactical. You know, they're almost transactional in some ways, but the longer success, I think, comes from just knowing each other and doing that on a regular basis and trying to work in each other's fields as much as possible so that we get it. I think there's a get it at some point, and you know, it's a goal. It's a potential goal. Does that answer your question?
That's great. You're there as a team, you support each other, and it starts at the local level and being at the table. Yeah. Thank you so much, Gail. Really appreciate your time today, and if we have questions for you, they'll be in the Q&A box.
Okay, I'll answer again. Thank you so much. It's been a pleasure to be here. I really appreciate the opportunity. Thank you.
Thank you, Gail.
Thank you.
All right, and
back to me.
Actually, we're going to go. Joanna's getting back on. And Larry, I was wondering if we could go back through the beginning of the presentation just a little bit. We had some questions on housekeeping. And for everyone here, you are going to get CEs for today. There's going to be a link as we close out the webinar. So do look for the survey at the very end. If it doesn't come up, we will email it out to you. I believe there's 2 CEs per webinar. And then the slides are posted on the American Association of Community Dental Programs website. The link is here, and it's also in the chat box. And to get CE credits, we just remind you to stay on the webinar for at least 85% of the time, or 100 minutes. And then please send your questions to the Q&A box, and when we get to the end, we're going to have a really strong panel discussion for about 45 minutes. And any technical questions can go in the chat box. And reminder, we have our upcoming webinars. So we have Planning for Successful Programs on May 13th, and then we're going to have some hot topics on the 27th. And we do want to catch up with you to see how this is going for everyone. So we'd like to do a poll. So I'm going to go ahead and start the poll here. And we're going to wait about 30 seconds. Thank you, everyone. And I know if you're on the phone, you're not able to do the poll, but it looks like numbers are coming in. We have about half the participants who've participated so far. Thank you, everyone. I'm going to go ahead and end the poll and share those, everyone. All right, so we have about 75% of the people said this has met their expectations. So thank you very much for your feedback. All right, and then Larry, I'm going to go ahead and pass it back to you.
Great.
Thank you.
Okay. Are we back to me?
Yep, we're back to you.
Okay. Couple of quick things. I want to thank Gayle for the presentation, and I want to remind everybody of a couple of things. One, let's see, hold on a second, because I'm trying to get my logistics here. Great. So one thing is that I want to remind everybody that not the entire audience is from California. We were scheduled to have this meeting in San Diego, and so we had a disproportionate number of participants from California, which is absolutely great. But I want to remind folks that aren't from California that that you'll be hearing quite a bit from California folks on these webinars. But that's because they're doing some really good stuff. But we want to remind everybody that the whole idea in planning for this and in selecting some of the presentations that we did was because we saw really good material that anybody could use and take back to their programs and transfer to their programs. So you may see some things or hear some things that right now are California specific, but they're presented because they are models that we can all benefit from, regardless of what state or community we're doing our work in. I also wanted to quickly remind people also that if you look at the program today, with all the great things that are happening, we couldn't do without dentists, but I wanted to call to your attention that none of the presenters today are dentists. Sometimes some of the leadership comes from other areas. And so now I want to introduce our next speaker, and another example of this is Lani Schiff-Ross, who is the executive director of the First Five San Joaquin program and has been in that role for 20 years. Before that, I might say, and again, she's a licensed clinical social worker. So another example of a non-dental professional. Before coming to First Five, she had an incredibly interesting and diverse career that included overseeing a teen parent program, worked in the field of gangs, domestic violence, sex offenders, child abuse, mental health, and it seems like that naturally brought her to dentistry. So, I take great pleasure in introducing Lani Schiff-Ross. Thank you.
Thank you so much. First, I just wanted to mention that it looks like the video is not on, but that might be a good thing. Katie, is the video showing?
Yes, we can see you.
Oh, okay, that's great because I can't
You
see
look
me.
great.
So I'm going to trust you on that. But speaking of video, so just so you all know, and I'll just fully confess, I have a little bit of pride issues here. And I don't want anyone thinking that I had breakfast and have some leftover breakfast on me. This is the week that I've had 2 presentations. And of course, this is the week that 2 fever blisters pop up. So that is that. And I also just wanted to mention, just building on what Gayle talked about, CDA has just been an amazing advocate, and they do the type of advocacy that where they really make things happen. So we are all incredibly grateful for that. Today, the theme is going to be about sustainability, and you'll hear about sustainability, you'll hear about First Five, you'll hear about some other programs as well. But one of the things I wanted to emphasize about sustainability is that everyone wants it. Grant writers or funders want it, foundations want it, and I can also tell you it's really hard. And the reality is when funding stops, those programs are never the same because funding did stop. But at the same time, it becomes even more important for us to look at how we impact and literally change a system. Next slide, please. So just a little bit about First Five. For those of you that don't know, First Five is based on the California Children and Families Act of 1998. It was a tobacco tax. It started with a 50-cent tobacco tax, and now there's other tobacco products that are also taxed. We focus on the prenatal to age 5, and we look at resilient families. We look at early learning issues, and we look at comprehensive health and development. So I'll be focused obviously a little bit more on the comprehensive health and development. Funding comes from different areas, and we're really grateful that throughout the state and the 58 counties that we have, different First Fives have received federal funding, state funding, foundation funding, and obviously our what's called Proposition 10, which was the First Five proposition in 1998. In terms of what our roles are, you know, as First Five agencies, we fund, we definitely fund. We have funded in our county, in the county of San Joaquin, about $200 million in the last 20 years. So we obviously have made a huge funding impact in this community. But more than just being a funder is what we do is we bring together diverse stakeholders. And one of the things I love, you'll hear about our program SJ Teeth in just a moment, but when we all meet together, it's not the same old group that meets. So there's different faces, and I think that's really helped to ignite people. Not to say that those same faces are not wonderful faces, but it's been really encouraging to see people from different organizations, from different areas, bringing together health, bringing together schools and education, bringing together social services, bringing together the field of those that serve in the special needs community. And it really does ignite people, and it's really made those connections. And as what was mentioned earlier was, it is all about those partnerships. It's about those relationships. And we've seen those relationships and connections happen. And we know services are only more enhanced and more effective when those relationships happen. We also build capacity. So it could be we fund board development for a community-based organization. We know in terms of sustainability, when boards are stronger, there's actually been studies that show their budgets go up 10%. So when we can invest in board development, we know that we're helping with sustainability. We also are looking at how we bring in innovative strategies to meet community needs. And you'll hear more about that as we go along. We also do some matchmaking, and you'll hear about that again as we bring together diverse stakeholders. There's matchmaking as we work with agencies and say, hey, you would be great with this group. We've actually helped other agencies bring in other funding through our connections with foundations, private foundations. And so it's not necessarily just about helping First Five get the funding, but really investing in the community, and especially when it comes to health outcomes. Next slide, please. So speaking of outcomes, so First Five is not just about funding programs to say we serve 20 million children, but we're really looking at results-based accountability, the RBA framework, and really looking at what are the results of serving those 20 million people. We're looking at both the qualitative and quantitative. And what's key for us is that CQI, that continuous quality improvement, and really looking at when we need to recalibrate those strategies. And so time after time, we're coming back and seeing and discussing what's worked, what hasn't worked, because we're always looking at the data. And that also helps improve our programs, which in turn provides the better outcomes. And foundations are very key into outcomes. So when First Five started about 20 years ago, we were the mean ones that wanted outcomes. We didn't want people just to report on the numbers and the outputs. And bit by bit, we've seen over the last 20 years, there's a huge growth with the foundations as well, saying the same thing. So as we talk about building capacity, we have a lot of agencies now that have been better equipped to apply for other funding because they know how to show outcomes. We also, and this for us is always key, is highlighting successful strategies for future funding and painting that picture of what it looks like. So foundations want to hear those success stories. Foundations want to hear those success strategies. They want to hear what's working, and they would rather invest in something that works, that's known to work. We still see foundations that want new ideas and innovation, but more and more foundations want to go with, again, what works well. Next slide, please. So again, partnerships, it's all about the partnerships. And you'll hear that theme throughout today, and I'm sure throughout all the other presentations as well. But we're also looking at issues of gaps and equity. So we don't want to always go to the same places that we've always gone. We want to look at what areas haven't been served, where there are populations that for various reasons, often issues of equity and lack thereof, aren't getting those services. So our care coordination that we provide for oral health, we're focusing on areas of special needs. We're focusing on the Southeast Asian community. We're focusing on the African American community and mixed immigration families. We're going into the schools that have high poverty, high free and reduced lunch rates as well, and high, which would mean high Medi-Cal or Medicaid rates as well. In terms of the partnerships, one of our executive directors of the Family Resource Network, and they work with children with special needs and their families. She said, when I took this position, my mission was to have Family Resource Network be known beyond the special needs groups. And SJ Teeth has made that possible. Knowing that everyone knows us and learns about the challenges and resources for families with children with special needs has been my goal. We do look at systems, and again, as we look at issues of sustainability, systems approach is the way that we will have that sustainability, because that's where there's that long-lasting impact. We've seen agencies really take on the issue of oral health for all approach. And now agencies, it could be a home visitation agency, it could be the food bank, it could be an agency that we have funded in the past that for various reasons aren't able to fund now, but they're still looking at issues of oral health. So we know while it may not be the exact same service that we had before when we were funding care coordination, that the fact that a food bank is asking all of their families and population that they serve about oral health is pretty amazing for us. Our goal is really to infiltrate the community with messages of oral health. Next slide, please. So just a few highlights of some First Five programs and how they are looking at sustainability. So Amador County is a rural community, and they only have one pediatric office. But through their oral health task force, they were able to help get that one pediatric office they now do fluoride varnishing treatments. And for some people, you may think we've been doing that for years. It's not a big deal. But for a pediatric office that's never been doing it, it's a huge deal. So this is something that when there's not funding for this program anymore, that pediatric office will be continuing to do that. This also leads to more accessibility because dentists in Amador County, to say that they are difficult to find is an understatement. Another program just to tell you about sustainability and seed money. And this is, again, a role that First Five often plays, is providing that seed money. So in Alameda County, in the Bay Area, First Five presented some seed money to get their county oral health program and the infrastructure support needed to get that going. Alameda County now is one of the role models for all of us throughout California and throughout the nation with their Office of Dental Health and all the work that they do. And again, that started with seed money from First Five. Next slide, please. Riverside and San Bernardino County, 27,000 square miles. They have the virtual dental home, which you've heard referenced many times, where they can increase the continuity of care and follow up with the care coordination. And then something else that they do is what's called the ECOA, the Early Childhood Oral Health Assessment. It's a mobile application. Home visitors can use it. There's a list of questions. They're able to then transition them to care coordination. But more and more programs are starting to use that mobile app. And again, when funding goes away, those programs will have that mobile app to talk to families about oral health. It starts the conversation, and we know with oral health, starting that conversation of brushing, flossing, etc., and eating healthy foods really, really can make the world a difference. So again, this is one of their very successful sustainability strategies. Next slide. And Gayle mentioned fluoridation. So fluoridation is one of the ultimate sustainable investments. And this is something that First Five Sacramento invested in. Community water fluoridation is one of the 10 greatest public health achievements of the 20th century per CDC. Next slide. And then just some local strategies here. Again, the enhanced organizational capacity as we're working with agencies. It's been really exciting to see home visitation programs now talk a lot about oral health, and we've provided oral health kits for them as well. Again, the oral health in all practices. A lot of this I've already talked about. We're going to give you an example in just a moment of some of the evergreen materials that we've been able to develop. We know through social media that can last and live on way beyond any funding. We're also working on grant writing as we look at future funding for our dental transformation initiative. And so that's happening now. And because of evaluation, which I'll also highlight real briefly, we're able to go to foundations, and that is our plan to show them that success. Next slide. Oh, and one thing I also wanted to add to on that is we are asking the State Department of Social Services that funds a home visitation program. We're actually working with them now and trying to negotiate that they would help fund an oral health care coordinator for that home visitation program. Next slide, please. So again, the partnerships, you heard about public health. So we work very closely hand in hand with public health from our media campaign. We have one media campaign that we both jointly fund. We also, in terms of partnerships, you heard Gayle talk about special needs and the work that CDA is doing. Our virtual dental home started out going to a school that serves all children with special needs. That school really has been transformed through this work. Kids that haven't been to the dentist in 10 and 12 years are seeing the dentist for the first time through the virtual dental home. Everyone from the principal is there to parents to teachers because they are so incredibly supportive of this program. Next slide, please. And then the public education campaign, as I mentioned, this is what can last beyond our funding. We have a website, sjteeth.org. We have a Facebook page, SJTeeth. SJTeeth stands for San Joaquin Treatment and Education for Everyone on Teeth and Health. and really taking that look and feel so it's out there in the community, so the community starts knowing and talking about it. Our goal is to increase conversations about oral health. Next slide, please. And Katie, can you play the video?
As a parent of a child with autism, finding a dentist has been a bit challenging, but that all changed thanks to our dental care coordinator. They helped us find a dentist who understood our needs and even came to our first dental visit. The dental office staff made sure both my son and I felt comfortable, and that there was extra time for our whole visit. On top of that, the dentist praised us for keeping up our dental routine at home, because good dental habits are essential to a healthier life.
Thank you. So we have YouTube, Instagram, Facebook. This is, a lot of this is new for us as we've expanded our reach. Again, getting messages out into the community, being able to share with funders our impressions and click-through rates, and all of these terms that are very new to all of us. But we know, again, we want to have impact. We want to have long-lasting impact. And we know we can do that through social media. So we've really worked to get creative there. Next slide, please.
As a parent of a child.
Thank you. So again, as I've shared about sustainability and evaluation go hand in hand. We need to be able to tell the story. We need to be able to share success stories. We need to be able to paint a picture. And we also need hardcore data to be able to show funders, foundations, continue to ask, is this effective? Is this working? And prove it to us. So there's some data that shows that this is working, this is effective, and we are able to prove that. And that's the end of my presentation. Thank you.
Thank you, Lani. Great program. Great things to think about. Great examples for many of us to be using and thinking about. I want to remind folks again, and I think Lani's presentation really points this out, is that there are many ways to look at sustainability. And they go beyond just going to your state Department of Oral Health and asking for a grant. There are many other ways to do this, and I'll actually address that a little bit more at the end. I also want to mention that want to recognize the support and assistance that we're getting from the UCSF to produce these webinars. We couldn't do this without the help and support from UCSF. So I thank you folks for that. Let's see, our next speaker is Rhoda Gonzales. And again, I mentioned that that sustainability for these programs can come from various places. Rhoda has had a diverse career as a dental hygiene clinical instructor, consultant, medical practice office manager, business owner, and as a consultant for a variety of programs. She has focused on improving health outcomes and the patient experience while reducing costs. She currently serves as the co-chair of the Government Relations Council for the California Dental Hygiene Association, and most interested to hear what Rhoda has to say about the Dental Hygiene Association, dental hygienists. Thanks. Go ahead.
Wonderful. Thank you so much for that introduction. So as Dr. Hill said, I am an RDHAP. So what does that mean? I am a registered dental hygienist in alternative practice that is specific to California. We'll get into that in just a little bit. But what I'm going to focus on in the next few slides is the sustainability of the dental hygiene workforce in community settings. Next slide, please. So California Dental Hygienists Association, they represent the workforce of 20,000 registered dental hygienists throughout the state and over 750 registered dental hygienists in alternative practice. Next slide, please. So what is our sustainability vision? Our goal is really to advance our profession of the dental hygienist in a holistic model within the dental and healthcare teams. We want to collaborate with our local oral health programs at the county level, as well as supporting AB 2207, which is a linkage of referring children to dental homes, and then also making sure that they're receiving their dental screenings with their initial health assessment in primary care settings. So what are some of these opportunities? We're increasing the access to care, and that's a focus of Dental Hygienists Association, as well as looking at how do we balance the workforce. By 2025, it is reported that there's going to be a shortage of dentists, while there's going to be an excess of hygienists. So we want to increase the access to care. Next slide, please. And what is our public health vision? So we're really involved on a partnership, collaborative approach. At a state level, we're involved with the Office of Oral Health. We're also involved in regular meetings with the California Oral Health Technical Assistance Center. On a county level, we're involved at local oral health programs, sitting as stakeholders in work groups. We're involved with the Dental Transformation Initiative. And then also we're working very closely with dental associations, with our local dental societies, and then academia and research entities. Next slide, please. So when we talk about California compared to other states, I think this model is really rich in that you can get a bird's eye view from a high level as how does your state compare to other states? What's an allowable task for a dental hygienist? And in California, we're pretty lucky that we've got a pretty broad scope of practice that allows us to work in many settings, public health settings, and then also receive direct reimbursement. And if you're a registered dental hygienist in alternative practice, it is even expanded greater. Next slide, please. So RDHAPs, registered dental hygienists in alternative practice, they are able to receive direct reimbursement from our state Medicaid dental plan. So it's called Medi-Cal Dental. And this is what the direct reimbursement looks like. Because our purpose of this presentation is sustainability, I think it's very important to talk about the price point of sustainability. So there's roughly 10 to 12 codes that the registered dental hygienist is recognized for payment, and these are the majority of those codes, and this is the price point. Next slide, please. So where can we provide these services? What kind of settings are allowable for a RDHAP to work independent of a dentist and receive direct reimbursement for those services? Those settings are the Women's and Infant with Children programs, so those are WIC sites, regional centers, so that's working with their special needs population, school-based sealant programs, health provider shortage areas, residences of the homebound, hospital settings, and skilled nursing facilities. Next slide, please. So I saw Dr. Hill's question, and it was about how do we ensure that when we're doing virtual dental home, or in this case, we're doing dental days with an RDHAP, that they're following up with a dental home. I believe that was his question. So I'm just gonna dive into this for a minute here. Doing dental days at a WIC site, in 6 months, we've documented that there was 372 children that were seen by an RDHAP. Of those 372 children that were screened, 58% of the families, the parents, signed up the paperwork. So in the middle picture, you'll see someone signing up the paperwork. And what we found is that 38% of those young children at WIC sites needed class 2 or class 3 referrals to a dentist. So either emergent, but routine. And we found that when they engaged with us, 38% did follow through. So that, I hope, answers with that question that I saw. But what we're doing is really educating, improving health literacy, and then linking. And that's where the care coordination that I'm going to talk about in the next few slides come into place. Next slide, please. So coordinating care, that's one thing that California Dental Hygienists Association is really big on, is collaborating. Linking our individuals to dental homes, right? So a dental hygienist is able to do prevention. That is not the end all be all. We want to coordinate care. We want to improve health literacy. When we are billing for prevention, they're non-competitive billing procedures, so that when our children that we refer, or adults if they're in special needs or nursing facilities, go to the dentist, what the hygienist is paid for, it doesn't compete with the dentist. For example, we're billed and we're paid for 10 specific preventive codes. When they go to the dentist, that dentist can still bill for exam, x-rays, any restorative procedures. So there's a huge collaborative approach, and a lot of us are referring to multiple dentists. And when those individuals show up, we've shown that no-shows are being reduced by 50%. We're also showing that our health literacy, by explaining what procedures they're expected to have, they're increasing their treatment acceptance. Next slide, please. So what are some of the barriers? So when we talk about sustainability, CDHA, we have a task force, and Central Valley Health Policy Institute completed a study. And the major barriers for the sustainability of registered dental hygienists and alternative practice are payment recognition. So we're doing a lot of the risk-based approach in the settings such as WIC, such as school-based dental programs, but we are not recognized for direct payment for that procedure of caries risk assessment, despite it being within the scope of practice, and despite taking a risk-based approach to everything we're doing and linking to dental homes. The other administrative burden that we're seeing is in school-based dental programs, receiving consent rates and valid insurance on those consent forms that are returned within schools. Also in nursing facilities, we know a large amount of our senior population has periodontal issues. They need scaling and replaning. This now requires a treatment authorization request, and that's an administrative burden. Next slide, please. So how are we doing on time? Okay, so I want to take a little bit of time right here, because I think this is important. This is kind of what we're here to learn about. What is the price point for sustainability? And I think this RDHAP salary per hour is very important, because to become sustainable, you have to bill Medicaid dental. We know the reimbursement is low. We know there's been some improvements, but we also know that to get the buy-in and get the trust of wherever you're working, a WIC site, a school-based site, a nursing facility, you've got to travel. You've got to meet with that school, and there's data entry. So this is something that I just want to plant in the seeds of individuals that are on this call. If you're a county that's looking to implement a local oral health program in your county, in schools, think about how you're going to help this program become sustainable. The first year, and I'm going to go into this in the next couple slides, or two, there's a low acceptance rate. But what we found is by year 3, we're up to an acceptance rate that does make it sustainable. So if you can become creative in a consultant position in some form of reimbursement to get this up and going, and it doesn't have to be this full amount for the first day, but maybe an hour a day, 2 hours a day to account for travel and meetings, that is helpful. Next slide, please. So if you're in California and you want to say, hey, I want to contact California Dental Hygienists Association, I want to locate an RDHAP, we want to implement this program. On this slide, we're showing all of the components. And there's 26 components within California, and if you reach out to your component, they're a great resource to locating an RDHAP in your area. Because again, too, this is commitment with partnerships on a community level. You want to work with someone within your community that knows the community for sustainability. And okay, so I've got a couple more slides here, and I'm going to dive into some work that's being done in Fresno, San Luis, and San Bernardino counties. So the Fresno County model, I have to say I'm a little bit partial to this model. I've been involved, I am from Fresno County, and I've been involved with this since the inception. So Fresno County in 2017, they got the local dental pilot program, and it was a 3-pronged approach. They did care coordination, they've done provider relations, and they've done access to care. They partnered, Fresno County Department of Public Health is the leading entity. They partnered with 2 strong community-based organizations in the community that already had roots and already had trust. What we found is that by implementing 24 outreach health educators as our care coordinators, we enrolled 20,000 children since 2017. We also, by using a salesperson approach and a community approach with our provider relations team, we grew our number of dentists from 87 to 180. And that's been really key because you have to have that infrastructure. We have now expanded to a school-based sealant program, which because of the care coordination team is more of a school-linked program. Next slide, please. Okay, so this is a lot of data. You can peruse this at your own, but the data is rich. And I'm going to focus in on the second line. What we know is that it is sustainable. What we know is that despite the fact of having 470 kids, only 115 said yes. Incentives work, but I think what's not shown on the screen that I really want to highlight is that when we screened those 115 of the 470 kids whose parents said, yes, I want to participate, we found that 10% had urgent needs. So urgent needs means pain, swelling. In our risk-based approach, we were able to use our care coordination team and link them to dental homes. And the families were so, so happy for this. So that's the highlight here. But take this data. I think it's important. You can peruse it at your leisure and then reach out if you have any questions. Next slide, please. San Luis Obispo, I do want to highlight their model because their model is different than Fresno's. They used a virtual dental home model. So whereas Fresno had linkages to multiple dentists, San Luis Obispo County didn't have multiple dentists. So they utilized a dental hygienist who is employed by a dentist, and instead of referring to a vast majority of 180 dentists, they referred to that same one within schools. And therefore it reduced the travel time because they were taking x-rays and exams in the schools, connecting them directly back to that one dentist. And that's been successful. So this year they expanded to 6 additional schools. Next slide, please. And I think this is a lot of data. You can peruse it at your own time. But I think what's important here is that the rate of growth has averaged 3%, and the number of children and schools has more than doubled. So we know it takes trust, we know it takes time, and that happens when you're engaging on a community level with the support of your public health department and community-based organizations. Next slide, please. So I'm going to be finishing up here in the next few slides, but I also wanted to share a model with Travis Trammell. He's also an RDHAP. He's an entrepreneur. He's also a PhD in San Bernardino, Riverside counties. So in the previous slides, we showed the low consent return rate of 5%, 7%. After 3 to 4 years, he's gotten that consent and participation rate up to 28 to 30%, making it fully sustainable. What he realized is getting consents during enrollment is key. Teachers are overworked. Incentivize them with pizza parties, ice cream parties, and establishing trust with families takes time. So if you start at a preschool level, by 2nd grade, when they need those sealants, you've established your relationship within the families and the schools to make that a success. Next slide, please. All right, so closing up, what are our future plans for CDHA? How do we work to continue to move together as a state within our counties and within our communities? We're currently strategizing new state dental guidelines. We're also looking at new policies to expand access to care. We're a part of a communication and stakeholder work groups for the Dental Transformation Initiative, as well as CalAIM. And we're involved with the Prop 56 supplemental payments, which you've seen on the previous presentations. That is a huge key. Also, we're involved with local oral health programs. One thing I want to highlight here that also Dr. Hill asked a question in the chat box about was how are we integrating medical dental settings? So this is something super exciting. Within a public health setting in Sacramento, we are right now integrating an RDHAP in their public health setting. And this is part of AB 2207, which is linking that dental referral to a dental home. So we know that when a child is seen at a pediatrics office, they're seen, what is that, like 17 times by the time they hit age 5, but we know a lot of them are missing that initial appointment with a dentist. So being involved in a primary care setting early, educating families, coordinating to dental offices is one of the keys in bridging that success. And the next slide. All right, that is the end of my presentation. I know we ran through it quick. I know there's a lot of data, but if you have any questions, please reach out to CDHA. You can reach out to myself, and I'm happy to be a resource.
Great. Can you hear me?
I can hear you.
Good. Well, thank you very much. That was an awful lot of things going on in your program. So I look forward to the questions when we finish up after our next speaker, who is Marty Milkovic. Marty has over 30 years of experience in management and is currently the director of care coordination and outreach for the Connecticut Dental Health Partnership. That is the dental plan for Connecticut's Medicaid and Children's Health Insurance Program. Before that, he was the executive director of the Connecticut Oral Health Initiative. And I found it interesting that he's had various senior executive positions with the United Way, including being a past president of the United Way of Connecticut. Again, Marty is another MSW, and he's got some, I think, some very interesting items to share with us. So turn it over to Marty.
Thanks, Dr. Hill. Can everyone hear me?
You sound great.
All right, thanks. Well, I am another social worker, which is kind of a surprise. I'm very rarely on a panel or at a presentation where there are other social workers, so that's kind of interesting. I'm also the token person from the other coast. So hi from Connecticut. It's lunchtime here, so if you hear any growling, it's not my dog. It's my stomach. Next slide. So just a quick overview of what I'm going to be doing over the next few minutes. I'll talk a little bit about my program, give you a little idea about what Medicaid looks like in another state, as most of you are from California. I'll do an overview of Medicaid, just so you have an understanding, because if you want to impact it, which is what will be next, you have to kind of understand how it works. And then finally, I'm going to spend probably a chunk of time on Medicaid administrative claiming, which is a not very well-known program inside Medicaid that allows organizations to be reimbursed for administrative functions that support Medicaid operations and clients. And then we'll have questions, of course, at the end. Next slide. So our program is Connecticut Dental Health Partnership. It's the Medicaid CHIP program for all of Connecticut. One program for the whole state. We have all the clients in the state. We're an administrative service organization operated by a private company, Medicare Dental Plans, through a contract with the state of Connecticut. Now, we're not a managed care organization. We're non-risk, meaning we don't benefit or suffer based on how much care is provided, other than, of course, we have some performance metrics that do look at that. We're just paid to run the program. The claims are paid on a fee-for-service basis, and we do everything and essentially everything else. We're physically in Connecticut. We have a very responsive call center. We have a very extensive outreach program and people in the community who work as almost community health workers and with others in the community. Next slide. And we've been very successful. In fact, we think our access may be the best in the country. As you can see by the chart, I won't go through all of this, is all of our clients, all of our members in Husky Health, which is the name of the program, Husky, like University of Connecticut Huskies, have a dentist within 20 miles. And even down to the distance of 5 miles, 96.7% of our clients have a dentist who is accepting new patients that close. The American Dental Association did a different analysis of access in Connecticut and also found it to be 99.9% of our clients had a dentist within 15-minute drive. So not only do we have a lot of dentists, we're blessed in that way, although we work to get to that point. we've had success in getting appointments. We've done mystery shopper surveys over the years, the last one in 2017. You can see 87% of the time, children were able to get an appointment, or actually the parent who was a secret shopper, within only 8.3 days. And then for adults, it was almost exactly the same, actually even a shorter period of time. I know when I try to get an appointment with my dentist, I can't get an appointment in eight days. Next slide. We've also been very successful in terms of child dental utilization, as some of you know, measured by the CMS 416 report. So it's comparable more or less across states. When we started, which was actually before this chart in 2006, or we started in 2007, but in 2006, dental utilization for children was only about 35% in Connecticut. We were in the lower third of states. It's now closer to 65%. It's gone up significantly over that period of time. And you can see the growth has been all really in that middle red bar, which is prevention. Treatment, the lower orange bar, has stayed flat or even might be decreasing, which has been a very positive outcome and exactly what we were looking for. Next slide. And we've reduced costs. One measurement of cost is PMPM, which is per member per month. So what does it cost to provide services for each person in a month? And you can see our child PMPM rate has been going down, and our adult rate has also been going down while we've been increasing utilization. And that's possible because the preventive increase is so much larger than what's going on in treatment. All the increases in prevention. Prevention is just cheaper. We always know that, but we've now shown that that is actually to be true. Next slide. Okay, now a little bit about Medicaid. You all know about Medicaid. Medi-Cal in California has different names in every state. As I said, it's Husky Health in Connecticut. It started in 1965. It's Title 19 of the Social Security Act. That's why you sometimes hear it referred to as Title 19, and provides funding for health-related services for low-income folks. Also, a parallel to that is a more recent program, the Children's Health Insurance Program, which is similar and in many states is more or less integrated into the Medicaid program. In Medicaid, there are different categories of people who are served. We have the ones you see there. States can divide it up different ways, although that's usually the way it's divided up. And you probably are familiar with EPSDT, which is the requirement in Medicaid that children really have access to the wide range of services that they would need. Now, that's Medicaid in a nutshell. However, it varies considerably by state. And when you've seen one Medicaid program, you've only seen one Medicaid program. It is not the same in every state. And in fact, in many states, it's even different across the states because the program is divided up by counties or groups of counties. Next slide. Medicaid is run nationally by the Centers for Medicare and Medicaid Services. They oversee the program. They have the ability to grant design changes to the program. Each state has to file a plan explaining how their program will operate, how it will meet the Medicaid rules, but there is a great deal of variability inside that. But even in addition to that, a state can apply for a waiver called a Section 115 waiver to demonstrate or experiment with different aspects of the program. So it's possible for a state to decide to do different kinds of things with that kind of waiver. And there are a lot of activities done under those Section 115 waivers. However, you rarely see dental in there, and that may be something that a state may want to consider, and advocates in the state may want to think about, that it's possible to be experimental. Next slide, please. Now, there are two most common ways that payment for care is done in Medicaid. Is fee-for-service, where the state itself or the state Medicaid agency pays for procedures directly, does their oversight themselves, although they can hire assistants to do that, and sets the fee schedule. By far the largest system, though, now is managed care. You're probably familiar with that. You'll have one or more managed care, well, two or more managed care organizations in an area, often a county or a group of counties, and they're paid on a capitation rate. Usually per person, so the dentist will get so much per person. And it can be high, it can be low. Managed care organizations make their profit from the difference between what they're paid by a managed care plan paid by the state and what they pay their dentists. So they have a kind of a negative incentive to restrict care. So therefore, it's very important in managed care that a state monitor what the managed care organizations do, and Medicaid does have quite a few rules and tools about that states can use to do that. Usually, though, a managed care organization will use another company, a subcontractor, a dental benefit management company, to operate the program and set the fee schedule and do capitation, maybe even a separate capitation system for the medical inside the dental program. Next slide. Now, there are other hybrids that are, as I said before, Medicaid can be different state by state, and there is a lot of variability. Many states have what's called a dental carve-out, where the dental program is carved out of the managed care system and put into a single program under one contract, which could itself be managed care, but would be separate from the managed care companies that run medical. Connecticut does have a carve-out. We have one program in Connecticut, although we don't have managed care. What we have is the next one called managed fee-for-service. The state carves out the dental, gives it to a single contractor, continues to pay the claims on a fee-for-service basis, and does the oversight of that contractor. And there can be mixes of this, as I said, within a state and between states. Every state really is different. Next slide, please. A new payment model that's becoming kind of popular, I would say, are value-based payments. That rather than paying for services provided or on a capitation basis, the idea is to pay for results. So if you can improve health outcomes or quality for the patients under your care, you get maybe additional money or separate money that would be on top of the usual fee-for-service reimbursements. There's no standardization of that across the country. Every state can design it differently. Many states are experimenting with that, and you really can't generalize that across the whole country. One other one common value-based payment system is the primary care case. It's called primary care case management, where a provider is paid a case management fee and is paid for fee-for-service and provides that care coordination and case management as an additional feature. Dental is sometimes done this way. In Connecticut, it does have a PCCM program that includes some dental, but not all dental. And you're going to see a lot more of these value-based payment models because we rightfully should be paying for results, not just for paying for services that are provided. Next slide. Lastly, and you've probably heard of what's going on up in Oregon with their coordinated care organizations, really just a variance of what's called accountable care. The accountable care organizations are larger groupings of providers and sometimes community organizations that share responsibility for providing care. It is more or less a value-based payment model. There has been a lot of success in Oregon, I know, in terms of their dental aspect of that program. They've been playing around with it to try to improve the results. I'm not sure what the outcome has been more recently, but it wasn't quite what they wanted in the beginning. And these are large systems, often hospital-based systems, sometimes new organizations that are created to do this. And often dental is just kind of an afterthought. I think you all know that dental doesn't always get the attention it probably deserves. I often say, and for those of you who are young, I apologize, you won't recognize this reference, but dental is the Rodney Dangerfield of healthcare. Next slide. So now I'm going to talk quite a bit about Medicaid administrative claiming, which is an odd title, and it's a program that isn't well known. And it is a potential way in the interest of sustainability for community organizations and local organizations to be reimbursed by Medicaid program for doing administrative tasks that are related to the Medicaid services in that state. And under the Title 19 Act that I mentioned earlier before, states can reimburse for the proper and efficient costs of the state's administration of the Medicaid plan. Now, most states limit these to certain organizations, very commonly schools, sometimes long-term support organizations. And it is possible for dental programs to get this. They're not specifically excluded, but they're not commonly mentioned. Now, there's no central database for these programs across the country. They also vary quite a bit, just like Medicaid programs themselves vary. And this is not a program that uses reimbursement like care being provided using procedure codes or capitation. It's a contract between the organization that provides the service and the state Medicaid agency, although there could be a pass-through through there. It's not through managed care organizations, and it's for non-clinical administrative services, although there is a little overlap there with some services like care coordination. These are contracts you would have to have. I see there's a question. What it's called in California is county-based Medi-Cal administrative activities. So you may be familiar with that. It's called different names in different states. It's not always called Medicaid administrative claiming. You've had it here in California since 1995. And under it in California, local governmental agencies can participate and receive the federal reimbursement in Medicaid. Now, Medicaid has two parts. It's a joint state-federal program, so there's state money in it and federal money in it. The state money could be local money that's used for that state match, but most often it's just state money. Most of it administratively is on a 50-50 basis. You can only get this if you have the contract. It isn't just like doing a service, enrolling and providing a service and submitting a claim. You have to have the contract. Now, county agencies are eligible for this, including their subunits like health departments, but they can contract that to local organizations too. And there even is one instance I found that there's a county jail in California that is currently getting money under this program. Now, as I mentioned, most states do this with schools. They'll reimburse schools for administrative tasks as they do under Medicaid. These local education agencies get that funds. But there are instances in some states of mental health programs getting it, intellectual and developmental disability agencies in a handful of states, and some aging services in a handful of states. Two other states I could find also had county systems where money came down into the county and county staff would be reimbursed. So it's a pretty flexible program, but it does have a lot of rules and requirements. Next slide, please. Now, in general, it must support Medicaid direct services. Not those services themselves, but the administrative services must be supportive of those direct services. There has to be proper documentation and allocation of the costs. They're very strict on this. There's a lot of auditing that's done for it. You can't use it for overhead costs. You can't use it to supplant other funds, particularly federal funds. And this is key, and this is key to understanding how to access this money, is you must have this included in the state Medicaid plan and approved by CMS. In general, the federal reimbursement costs are 50%, but it can be up to 75% for certain skilled medical professionals who provide certain services. For example, one service that is actually not so much a skilled medical professional, but translation services are reimbursed at that higher rate, which is 75%. Next slide, please. Now, the services that can be reimbursed, so long as they are focused on Medicaid, referral coordination and monitoring of Medicaid services, such as enrollment support, so assistance in enrolling people, or as you can see later, even doing outreach for enrollment, care coordination and case management, transportation services for Medicaid clients, translation services for Medicaid clients, training around all of this, so again, so long as it can be linked to Medicaid's direct services, and even program planning, policy development, interagency coordination. So you can be reimbursed for time spent on coordinating, so long as that coordination helps Medicaid or improves Medicaid services. Now, you can see, but to get into this, you really have to have a good relationship, and we've been talking all today about relationship building with the state Medicaid agency. Now that's the executive side of the government that manages the program, but you also need to have relationship with the legislative side if you want to implement a program like this in your state. You have to build your case. You have to be able to explain why this is important and why it should be done. Next slide, please. You have to make sure you meet all the criteria. You have to convince the state Medicaid agency. You have to have the cash matched either through the state or through local monies. And you're going to ultimately have to convince CMS through your state Medicaid agency to do this. As I said, in California has a system in place right now, so you could learn how that system works for you California folks and see how you can impact through your local county government. Again, I'm sure relationship building and advocacy will be important in that. Here are a couple of references to that. This is the CMS page on Medicaid administrative claiming. And then, as I said, mostly schools do this, but I found the next reference to be a very good example of a manual on how this can be done. Next slide, please. So impacting Medicaid funding is not a simple answer. It's a complex system. We've all had bundles of wires and string like that picture, and that is a good analogy for what Medicaid is. It's complicated, but you need to know the lay of the land in your state. How are the payment system used? Who are the players? Who's involved? Who are the people? Relationships are built with people primarily, not so much the organization. You should have multiple connections actually in organizations in order to maintain relationships. And as it is true for almost everything, knowledge and relationship building is the key. Okay, next slide, just a couple more. So get the details of how Medicaid works in your state. You can enhance your ability to sustain yourself through direct services, and that's important to know what codes are used, know what the CDT codes are, what's flexible, as Rhoda mentioned earlier. She knows what codes that hygienists can bill in California in independent practice or separate practice. Know your state Medicaid office. As I said, they have most of the power to do that. And it's a political process as much as anything. You got to impact both the legislative and the executive branch. Next slide. And just a quick slide on, as we originally planned this, COVID-19 wasn't a factor, but here are some of the things that Medicaid has been doing. They've increased the federal share of Medicaid by 6.2%, which I assume would apply also to the administrative claiming. There's several other things. I won't go through all those. There's also emergency waivers, 1135 waivers that allow variances in the program that many states have used. There's the loan programs you're probably familiar with. So states have done a lot with that. And I'll close with one important metric that some of you have probably already seen that was done by the American Dental Association's Health Policy Institute. In a survey of dental practices, they found nearly half of practices say that unless we get back to normal, they may be out of business by August. That's a chilling statistic, and we should all consider that in terms of not just the sustainability of our individual programs, but of our whole system. Next slide. Some more references you can look at later. And next slide. Thanks very much.
Hi, everyone. Thank you so much for your understanding. I apologize. I had technical difficulties. My computer just shut down on me, and that's never happened before, and it just took me a while to get it up and starting. So again, I apologize, and I thank you for your patience and for going with the flow for this. We had Gayle Mathe to start today, and because she couldn't stay with us the whole time, we were going to do her presentation and then go back with housekeeping. So I thank Katie for jumping in and going through housekeeping. Katie, could we have the agenda slide? So as we are moving forward, I wanted to just reiterate yeah, just the agenda slide would be great. that, you know, today we're talking about building a sustainable local oral health program. We are so fortunate that we had this amazing group of panelists. Each one had their own perspective on this idea of programmatic and financial sustainability. We thank each of you. And so our next move would be to go to the Q&A section. And you know, we, with these webinars, especially because we can't be in person, we really wanted to hear from you and communicate with you. So we are asking that you use the Q&A box and please ask questions. You know, our panelists are happy to be here and answer questions. Like I said, we heard from many different perspectives, so it'll be really great to have your questions answered by them. If you would provide your name and organization, of course your question, and maybe the panelist that it was intended for in the Q&A box, we'll try to go through as many of your questions that we can. So I know that Dr. Hill, he wanted to thank a few people. So before we invite all the speakers to join in on the panel, I'd turn it over to Dr. Larry Hill for just a moment. Hi, Dr. Hill.
Let's see here. I'm muted by host. I'm unmuted by host. Okay, great. So I too want to thank all the speakers before we get to the questions and section, but I wanted to make sure that that we made a couple of notes here. One is that the presentation that Marty just gave on the Medicaid administrative cost reimbursement is, as he said, is a complex issue based on relationships in my own state. We actually tried to get that done and we weren't successful. But I can tell you that if you think about it, the cost, the reimbursement, the potential for reimbursement is tremendous. And so, speaking to Jared Fine and folks from California, Jared is working with Jay Kumar, and I think the plan is for there to be a webinar sometime in the near future with some specifics on how to make application for these dollars. And as Marty mentioned, there has to be this relationship and agreement with the state Medicaid office, but it is something that's worth pursuing. Relationships being very important. Sometimes there may be a hesitancy for one reason or another at the state Medicaid office to go for these funds. But I think perseverance on your part in convincing your state to go after the funds can be a significant piece of sustainability for your program. So that was one thing I wanted to mention. The other thing I want to mention is that sustainability is, you know, as I said before, it takes many forms, but it's really important as you think about where and how to find funds for sustaining your programs, that one, that you get out of the office. You have to be available to hear what else is going on in the healthcare access area in your county, to know where to insert yourself, and to know if we're not there to remind people that there are dental programs out there that need to be funded or need to happen and be funded. If we're not there to do that, nobody else is going to do it. And so it is a very important piece. Another piece is not to wait for a specific dental grant to come out or a specific notice from your state health department that there are going to be dollars for a dental program. you should be looking and creating the relationships with folks so that you find out when there's a maternal and child health grant that may be coming out that may not mention dental in it at all, and they may not, the folks that put out the request for proposals may not have been thinking about dental. But it's our responsibility to think about dental, and we can be contacting those folks and say, hey, I have an idea that's consistent with your RFP, but it pertains to oral health. Would you guys entertain a project like that? And I know a lot of folks that have been successful in getting grants for programs that never mentioned oral health. But we're the ones that have to plant those seeds. And one last thing is, it's always good to have an idea, even a proposal for something that you're thinking about in your desk drawer, so that when an opportunity arises for one of these grants that may or may not have mentioned dental, you can pull that either that full proposal or that outline for proposal out of your desk drawer and compete for funds. So the real answer there is to be ready. And I want to acknowledge real quickly all of our speakers and our planning committee, Bahar Amanzadeh, who was taking a back seat today because of not feeling very well, but Bahar has kept his planning committee together. Jay Kumar, Jared Fine, Myron Alukian, who I mentioned is now recovering from COVID, Katie Roland, who did the registration, and a thank you to the University of California, San Francisco, Steve Silverstein for his group and his whole group in helping to make this possible. With that, I'm going to turn it back over to questions and answers to Joanna.
Thank you, Dr. Hill. That was great. Okay, so now we would like to invite all the speakers to a panel, and I would like to start with a question that we have in the Q&A box, and it's for Marty. Marty, can you hear me?
Yes, I can. Can you hear me?
Yes. Okay, great. Thank you. Okay, Marty, so the first question is from Erica in Tuolumne County. She's with the Smile Keepers program, and she asks, are the billing service business model for Medi-Cal services with school-based programs? Are there billing service
Yes,
models?
and as I mentioned, there are across the country. In fact, if you just, it's a Google thing, go out and Google it, and you'll find manuals. There are manuals in every state practically that have school-based programs on how it operates in that state. And there probably is one in California, I'm sure there is. And there is a website that I didn't mention in the presentation for the program in California. But if you went into that website, Google the name of the program, and went in, you would find the manual, which certainly includes the school, local education agencies.
That's excellent.
Can I jump in and
Sure.
answer that as well? So our virtual dental home goes into the schools, and they are an FQHC, federally qualified health center, and they do bill for the VDH, the virtual dental home. They bill to Medicaid or our Medi-Cal program. And so similar to what Rhoda was saying earlier, that doesn't interfere then if that same student were to go to the dentist and bill under Medi-Cal dental. So that wouldn't cross over. So there's no, again, competition there. But the goal is that after these years of having the dental transformation initiative, and this is the 1115 waiver in California, for services under Medi-Cal, the goal is that they'll be sustainable because they'll build up that billing amount, as Rhoda was talking about, that it takes a few years really to build up. But yes, so school-based billing has been very successful.
That's excellent. Thank you both for that input.
Yeah,
Okay.
if I could just add, there's
Sure.
almost every state has added some kind of teledental billing code, which may disappear after the COVID-19 crisis, but actually may still be around. So that certainly is something that you should be looking at.
Definitely. Well, speaking of COVID-19, there was a question for Rhoda. And Rhoda, they ask, how do you think COVID-19 protocols will affect RDHAP's ability to provide preventive services in community settings?
That's a great question. I'm excited to announce that CDHA tomorrow will be having a town hall sharing what we're learning. I don't think we have all the answers yet, but Governor Newsom in California has put together a reporting to practice work group, and CDHA is working with CDA, with CDPH, Dr. Kumar, and others to develop what those guidelines will look like. I know it will look different. We just don't know at this time what to expect.
Okay. And that's how it is right now. Everything is changing on every day, but I appreciate that response. Thank you. Okay, the next question is for Lani. What do local foundations in general look for when oral health programs approach them for funding?
They look for success. They look for, they're all going to look for, again, sustainability. So having some kind of system in place that if a foundation is going to fund you for 3 years, what is the plan for post 3 years? Larry mentioned having, a plan in place in your drawer. So having, working on, we have an abstract as an example that we can pitch. But to be able to say, here's our past successes and here's how we know that your investment will be long-term. So foundations know that they can't be there forever, but they want to know what can help last forever. So having those examples will help your proposal go a lot further.
Excellent, thank you. Anybody else have anything to add to that?
I just want to mention one thing. If you go back to, if you go back to the beginning of the Obama administration, when President Obama, right after he got elected, there were funds that became available for programs that they were looking for programs that what they referred to at the time were shovel-ready programs. And I have to say that there weren't very many real shovel-ready programs because it's expensive to get to shovel-ready. It means you have an architect, that you have a contractor, you're all ready to go. And most programs don't have that when they don't have a promise of funding for it. But post-COVID, I guess my message is that we should be really thinking, keeping up with everything that's happening every day right now, because once we get into this near post-COVID era, there is going to be a lot of planning going on for what we can do to improve both the health delivery and the public health systems out there. And so folks need to be ready to jump on those things, and you can't do it if you're not aware of what's going on. So read the newspapers, get on the dental public health listserv, get on the ADA listserv, read everything that you possibly can so that you're ready, that you're thinking about the potential for those funds.
And just along the lines, just to add also, is during this time and even previously, is capture those stories, because foundations do want to hear those real life stories. So do the emotional, plug and tell the story of someone whose life really has changed, whether you were able to get them into care and it's an adult and they now have, dentures and they get a job and et cetera, et cetera, et cetera. Or again, a young child or kids that, with special needs that haven't been to the dentist for 12 years and literally lives that have been changed. So tell those stories, capture those stories now. So you have them, because as much as we think we'll always remember, we don't. But that emotional connection also can really help with funding.
And now is an excellent time to build those relationships that give you the information that Larry mentioned. And really, people are available, they're home. So calling and talking to them, trying to understand how that foundation or how that funder thinks and what their interests are. Because you want to match that program you have in your drawer with those that have the same interest or a close interest. If you know what that is, you can even modify your program to meet that interest more closely.
Mm-hmm.
One other thing that I might want to mention real quickly with Gayle not, having to get off early, is that California, the California Dental Association and the California Public Health folks have a very unique relationship. And it is not the norm to have the public sector and private sector working as well together as they do in California. And as a result of that, they've been able to accomplish a whole lot of things that, we haven't seen happen in other areas. So again, it's relationships. And my message to the public health folks is that at times, while it may seem difficult, seek out the champions, seek out somebody in dental association leadership to begin to establish a relationship to help open the doors, to collaboration, cooperation, relations, because it's ultimately, it's very important to have that.
Yes, that's all excellent. I had a general question for the panelist, each panelist. Address whether any of their programs integrate oral health with primary care, such as electronic health records, bidirectional referrals, etc. And I'll open that to anybody that would like to start, but we'd like to hear from you all.
So I can start. Currently in California, we are working actually in Sacramento County, where we are implementing a program with a dental hygienist and alternative practice, working in a public health pediatrics setting. And that is just getting up and going. So I do not have the results of it yet because we are literally just implementing that. But she will be entering into the electronic health records, as well as educating the medical primary care setting as a unit on the importance of oral health and how to do assessments, how to apply a fluoride varnish. So we're super excited to see the results of it. We just don't have that data at this time.
Yeah, I look forward to that.
We also have care coordinators that work in the medical settings. So they do follow up, they get referrals from the pediatricians, and they do that follow up for oral health. And then we also have care coordinators that work at our FQHCs that are entering data into the EMR. So it becomes very holistic approach care.
That's excellent.
We have a program where we outreach to perinatal women in the Medicaid program. And between 2009 and 2013, we increased the utilization of those women from about 38% to about 50%. And we worked quite heavily with OBGYN offices.
That's wonderful. Okay. So the next question is for Rhoda. Rhoda, when local oral health programs are looking for partnerships in schools, what should they look for when soliciting applications?
I would definitely say look for somebody from your community who knows your community. I think when you look for sustainability, if you choose a partner who has a track record or has a relationship in the community, that goes a long way. If you partner with someone from outside of your community coming in, they oftentimes don't have relationships with the community-based organizations, with the dental providers, because you have to establish a dental home. You don't want to come do work and then leave, and then what happens 2 days later if the family or the child has a concern. So I would definitely say look for someone within your community. Reach out to your president or their dental society, look for your CDHA component, and find someone within.
Mm-hmm. Lani, would you have anything to add to that question?
I think what she just said, what Rhoda said was great in terms of just building on those existing relationships in the local community that has a pulse of what's going on. I think in terms of working with the schools, it does take a lot of work. And again, Rhoda mentioned that. So having the, being out there when kids are being dropped off, having people that can develop relationships with the school secretaries because we know they rule the schools, getting to know the teachers. And also, if you're establishing a school program, is not putting the onus on the teachers. And so whether it's bringing the all the paperwork, making all the copies, dropping things off, picking things up, the less the school has to do, the more likely they'll want to be engaged. But showing up at the PTSAs, the English Learning Advisory Council, the ELACs, just really getting involved in the community culture of the school. And that is what we have found to be more effective in terms of reaching more students.
Well, that's really helpful because we have a lot of feedback from our local oral health programs in the state of California. And sometimes it's learning how to build those relationships, who to contact at the school and how they can best help move those programs forward. And it really is understanding the community and that they get to know you, building that trust. So yeah, I can see where the trust is a really big issue. There's a part 2 to this question. They ask, what kind of training outcomes or approaches should they look for to assure quality of services?
So we look at parent satisfaction as one of the examples. We also continue to maintain contact with our schools to get feedback, to find out what's going well and what's not going well. And we need to be willing to ask those questions about what's not going well. Again, applying the continuous quality improvement model to that to see what we can improve.
With our care coordination team, we do follow-up calls. So one of the things is that we make reminder calls to families, and then we also follow up. So quality really is built into our program as well. We want to make sure that they got the care they needed and they were happy with the care that they received so that they will go back for their continuity of care.
I think you also have to think about, you can have the best technical person providing a program in a school. They can collect data great, they can do the sealant applications great, they can do everything great, but they don't have the personality necessarily to win over the folks in the school. And we have to remember that in school-based programs, one of the big things we have now is the emphasis on the sciences and math, and so they're under a great deal of pressure to produce test results. So it takes a special person, and that person may not be the person that you want to send out in the field to do the work. It may have to be somebody else that's behind the curtain, who's actually on the phone and making the contacts with the school to sell the program. But I think we always have to be aware of who's on site and their ability to interact with other folks.
Yeah, and Larry's bringing up we need to learn to speak their language, not ours. And so their language is average daily attendance and ADA, and helping them see that kids staying in school helps their financial sustainability. And so we are actually going in to help them get more money from the state and serve the kids.
Yeah, I'm not sure that we mentioned enough the importance of the school nurse, because oftentimes in the schools, that person is the key. It's who the principal looks towards. It's the key person, and that person may be frustrated with dental over the years because they don't have the time to make the referrals, they don't have time to do the follow-up, or they just don't know, they don't have a dentist that they know of that they can send the kids to when the kids come into the office with a toothache. But I know in our program, the school, we went for 25 years trying to figure out how to work with the school nurses, and suddenly they came to us when they saw that we had the mechanism to get these kids into care and that we would take the load off their shoulders. They came to us and said, will you train our school nurses to do oral health assessments when they do vision and hearing screenings. And I can tell you the number skyrocketed in terms of the case finding that we did, the success that we had in getting those kids to dental offices. It was just incredible. And it was all school nurses.
Yeah, it's true. You find that champion at the school that can help you. Yes. Well, we've come upon the hour. I want to thank each of you so very much. You know, each presentation was just so helpful. We got a lot of great feedback from the audience. And in our final minute, we would like to do one more poll. Kitty, could we have the poll question? We're hoping that everybody will participate. So the polling question is, what did you like the most about this webinar? So while everybody's having an opportunity to answer the poll question, we appreciate your participation with that. It's really helpful, and we appreciate all of the questions. Dr. Hill, would you like to do a closing?
Yeah, I just want to thank you. I want to thank everybody for participating, for being on, for being patient with this format that we have while you find us struggling around trying to go from one person to the next and whatever. And again, I want to thank the California Dental Association, California Department of Public Health, the Oral Health Program, DentaQuest, the ADA, ADEC. I want to thank all those folks for helping us to make this happen. So have a great couple of weeks until we have an opportunity to do this again.
Yes, our fourth webinar will be on Wednesday, May 13th from 9 to 11. So it's planning for successful programs. So we hope to see you all then, May 13th. Thank you all. Have a wonderful day. Thanks again for our presenters.
Thanks. Thank you all.
Take care.